Hello everyone and welcome to the thoracic imaging session. My name is Savraj Kalsi and we'll start this session off now. As a reminder to look back at the introductory section, but we have gone through a couple of different approaches in terms of a system to look at CT scans. But remember, two key things to do are to use that system and to refer to previous images as well. So the A to E approach that we covered in the last session was A for airways. So you're looking from the top down, check if everything is midline in terms of the trachea and the mediastinum. With the breathing, you want to make sure you can count enough ribs to make sure there's adequate expansion, and check the lung markings go to the edges. Check the costophrenic angles to see if there's any blunting and possible effusions. C is circulation, where you look at the size and position of the heart and the hilar branches. D is for disability, so that's any fractures of ribs, dislocations of shoulder, and check the vertebral bodies for any dislocations there as well. E is for everything else, so you've got free air under the diaphragm, indicative of a perforated bowel. You've got subcutaneous emphysema, gastric bubble position, and you can see anything else like clips and wires, ECG cables, hiatus hernias, those sorts of things. And the next one was basically a different type of A to E or A to I system, looking at the airways, the bones, soft tissues, cardiac again, diaphragm, seeing if there's any flattening of it, looking for any effusions, and then you move on to the field, see if the fishes have any fluid in them. Often you'll find children will have foreign bodies, for example, swallowing of little toys. And then you look at the great vessels and the gastric bubble, hilar, mediastinum, and eventually come to an impression of what you think is going on. And as a junior, it's always good to hazard a guess, and it's not always, it's an informed guess rather than a just a stab in the dark, because you're obviously using all the years of training you've had and the lectures and anatomy you're aware of to come to a conclusion of what you can see on the radiological scan. But by putting something down, it means that you're committing to it, and it will just help you in your learning process. There are 4 key review areas to look at for chest x-rays or thoracic imaging, especially plain films. So pathology can often hide in these areas, and so it's always good to review them or go back and look a little bit harder. So those are the apices, the hilar vessels, the cardiac shadow can be quite large, and so you can miss things. And the diaphragm is quite a large structure, and it's often compounded with the sort of liver behind it, or under it even the stomach and spleen. So the lung markings, immediately next to the costophrenic angles, you may not see the markings there because often vessels are too small, and so you can't really see them on a plain film. So I wouldn't worry too much if just at the costophrenic angle, for a small amount of space, you don't see any lung markings. But if they are there and they're pronounced, then there may well be some interstitial disease or some edema. Now, you may well have heard of cardiac shadows and assessing the cardiothoracic ratio. Now, this can really only be done in a posterior-anterior plain film. And the reason behind this is that if you see here, image taken from KenHub, this is the heart border, and this is a lateral view of the thoracic cavity. And so if you're taking an anterior, so this is your anterior side here, I'll just annotate this. So this is anterior here, and you've got posterior here. And so if you've got an image projector sort of, you've got your x-ray machine here, and you're sending out rays which are going in this sort of direction, and again like this. These rays are going to cast a shadow like so on the back of the on the back of the actual board that's capturing the image. So I'll put that in a different color here for you. And so you've got a board here, and by having it anterior posterior, the size of the heart, as you can see, instead of being, let's say, this large, is now exaggerated to being this large. And so you cannot accurately assess images anterior to posterior because of this. So to accurately assess the cardiothoracic ratio, you need to have a PA, so a posterior anterior film, and then you can use the measuring tool on all your PAC systems to see what the distance is of the heart from one side to the other, and compare it to the thoracic distance from the widest part of the thorax on the right side, for example, all the way to the left side. And if it's greater than 50%, then you have an enlarged heart. So, all the theory done. Let's see if we can read a few chest x-rays now. So one of the small system to run through is Dr. Ripe. So this was something that's covered in a lot of medical schools. But if you look at the D in doctor, that stands for details. So those are things like the patient's name, date, check for any previous scans as well for comparison, like we said, one of those key rules. You then want to look for rotation, so you need to check if it's if the sort of the distance between spinous processes and the clavicular heads is equal. You're looking at inspiration for I, so is this adequate? And again, you need to, x-rays are taken when patients have taken in a deep breath, and so you should be able to count those ribs. So if you're counting anterior ribs, normally it's about 6 you need to count, and posterior is around 10. And then if you want to look at penetration, you need to see if that's adequate. So can you see the spine through the heart? And if so, then you've got an adequate penetration. And with the exposure, can you see the whole of the chest? Is any sections cut off? You need to check if you can see the shoulder joints bilaterally, with the apices in there, of course. And it has to go all the way down to the bottom of the diaphragm. So sometimes with people who are, let's say, COPD patients, they have very large chest cavities, and so they may well actually take the plain film in 2 sections just to capture the whole. So here is a chest x-ray, plain film. Please feel free to pause your video at this point and make an assessment of what you think is going on here, if anything. So hopefully you're coming back from pausing it and gathering your thoughts, and you'll be glad to know that this is a normal chest x-ray. There's no pathology identifiable on here. It's a PA, posterior anterior film, and you can see that the shoulder blades are moved all the way to the sides. You've got good exposure here, so shoulder blades all the way off to the sides here, the scapulars, and you've got good inspiration, so you can count the ribs, and you can see there's 10 ribs here. So those are up here: 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And you've got good penetration, so I can see the vertebral bodies here behind the heart, and exposure is excellent. So you've got apices up here, in line with the clavicles and the shoulder joints. Ideally those could be included, but it's not essential. We're not taking this image for the shoulders, but we have all of the chest cavity here, down to the diaphragm. The costophrenic angles are all visible. Good. Second one here. Please pause your video now. Okay, so in this plain film we have on this side here a pleural effusion, with the trachea actually being pushed to the right side, if you can see. So if this is here the trachea, and it's coming down and going off to this side. And this here is your pleural effusion with the meniscus tracking up here on the side wall. Good. And in this plain film, please pause, and you can obviously have a go as well. Okay, and so in this image here, you can see the trachea is coming down and actually going to this side. Now, this is the side where we have the pathology, and this is in keeping with the right lobar collapse. And so the trachea is pulled towards the pathology in this case. And so what I've done is I've gone and created a little table here. And this table basically helps you identify the tracheal position in common pathologies that you may well come across. So the position stays fairly central if you've got things like a consolidation, any pulmonary edema, mesotheliomas, and small hemothoraces. Any large hemothoraces may well actually push it away from the whiteout if you think about just the pressure building up in that side. Now, talking about pressure, I've mentioned here tension pneumothorax, but that should be a clinical diagnosis, and so you shouldn't actually be getting a chest x-ray showing a tension pneumothorax unless it was done for some other reason, and that happens to be an incidental finding of sorts, or it's already been managed and it's resolving. But again, you wouldn't see that very well on chest imaging if it is resolving. And so the next image will show you what I mean. So this is a left-sided tension pneumothorax, as you can see it here. You can see the left hemidiaphragm is actually depressed. It's compared to this side, it's lower. There's a step in it and it's coming down. And the heart is shifted to the other side. So you've got tracheal deviation. You've actually got mediastinal deviation as well. So the heart border is all pushed across. And so the left lung is very, very tiny. If anything left off it, it's all moved across because of the tension pneumothorax all on this side. Good. Please feel free to pause your video at this point. And here we have the left lower lobe being collapsed. So if I can convince you that there is a line coming down, here, and so this is your sail sign, and it's indicative of a left lower, or whichever side it's on, is a lobar collapse on that side. So dense triangular opacity overlying the cardiac shadow is a sail sign. Alright, it's just the fancy term for it. Good, here's another plain film. Please pause your video and see if you can comment on what's going on. Good, so here, if I get my pen again, we have the horizontal fissure here. And so we have a right middle lobe pneumonia just under it. And you can also see the loss of the heart border as well on this side. If this was to be a lower lobe consolidation, then you'd see a loss of the right hemidiaphragm contour around here. But that's a good differentiation between middle lobe and lower lobe. Middle lobe, you'd lose the contour of the right heart border, and if it's lower lobe, you'd lose the contour of the right hemidiaphragm. And here I'll show you a lower lobe consolidation for comparison, where it's very difficult to make out. I assume the diaphragm is here, but it's very difficult to make it out because you've lost that clarity there due to the consolidation. Good. Pause your video and have a think if there's anything you see abnormal in this plain film and what it might be. Okay, so this one, yes, it's actually a patient who had a mastectomy from breast cancer. So I'm not sure if you can appreciate here, but the breast on this side is missing, and so it's a post-operative scan, but otherwise the lung fields are actually clear. Good. Alright, so this is a very common foundation year scan or dilemma you'll be faced with. Nursing staff will come to you and ask you if they can use the NG tube. So pause the video, see if you can find it in both the left and right scan and see if it's in the right position. Okay, good. So NG tube placement. So there is a few things that you need to check. So obviously, to have it as a good chest x-ray, all the Dr. Ripe we went through, but the NG tube should remain in the midline, which it's doing here. Good. It needs to pass the level of the diaphragm. Now this doesn't do that, so the diaphragm is here, and the NG tube, you follow it down and ends up here, and so this is actually going down the right bronchus. And so this tube is in the wrong place. On this side, this is the NG tube here coming down. You can see it's staying in the midline. It's past the level of the diaphragm, which is here. It's bisected the carina, which is the junction where the trachea would split. And then the tip of the NG tube is clearly visible over here, below the hemidiaphragm, and it's approximately 10 centimeters beyond the GOJ. Alright, that being the gastroesophageal junction. Okay, so moving on to the next one. What would this plain film be diagnostic for? Please pause your video. Okay, so this plain film, as you can see here, there's no significant pathology in the sort of main chest cavity. However, if you look underneath this diaphragm and here, you can just, if I can convince you that there's a line, there's two lines here and a gap in between. Air is dark, and so that's air underneath the diaphragm. Underneath the diaphragm here, with the liver underneath it. And so in bowel perforations, with the bowel having air within it, if there is a perforation, that air rises, and so it'll come to the top here, and you'll see it as pneumoperitoneum, or air under the diaphragm. This may well also be secondary to insufflation from laparoscopic surgeries, and thankfully this was the case here. But in any case, this is a worrying sign, and it's indicative of a bowel pathology, usually perforation. Okay, and if we move on to the second last case of chest x-rays that I have, this is a plain film. Use your system to read it. It's an 87-year-old male. And pause your video now. Okay, good. So this is a PA film, posterior anterior film. As you can see here, sometimes they give you a little bit of a guidance, including the side as well, just in case you've forgotten. But the convention is to have the left side on this side here, as it is shown in this image, and the right side on the other side. So this is a PA film with a large rounded opacity in the right lower to mid zone, as you can see here. And this actually triggered a CAL alert, which is a cancer alert, put on chest x-rays, which then goes on to have an urgent CT thorax done to further identify what the lesion may be and try and stage it if possible. The left lung itself has no significant pathology of sorts. And a final plain film, if you pause your video, I'll give you the answer shortly. Okay, so this is cannonball metastases. As you can see, there's many cannonball-like lesions, and the primary is usually renal cell carcinoma, but you can have a choriocarcinoma as well. They tend to be large, well circumscribed, and round in their appearance. Good. So CT chests is not something you would, as a foundation year doctor, be expected to read in any capacity. So if you feel like this has been more than enough and you want to just get a few hints and tips and see the feedback area before you leave, then please do skip towards the end. But for those keen to explore some CT chests, stay tuned. Here's case number 1. So we have a 60-year-old with a 3-week history of cough, chest pain and coughing up of blood, with the background of sarcoma. This is a normal windowed CT chest. For orientation, what you have in CT is a view from the feet to the head, and I'll write on here again, like chest x-rays, this will be the left side and this will be the right side. Okay, so we're starting at the top here just to show you the anatomy. So I'll scroll through manually, and here you can see what develops off it. So here, if I use the pointer, you've got your trachea, you've got your spinal bodies here, and you've got ribs on the outside. As we keep coming down, you'll see the chest cavities here opening up. At this stage, you can see here trachea, esophagus. This bright color is all contrast that we've given the patient. Good. We keep going down, and again, remember the sides we're looking at. All of these are small pulmonary branches coming off, and so if you've got a CTPA done, you would see a filling defect if there was a PE here. So instead of being solid, you'd have like a small area where it's grey or dark within this vessel, and that's what you would call a filling defect. But again, outside of the scope of foundation doctors. Let me remove that. And here now you can see this lesion appearing on the right side. Okay. Keep scrolling down. You see the liver appearing on the right side now. Left side is a gastric bubble. And that's it. Good. Now what we've done here is we've managed to get the same case but with chest windowing, and now you can see that it will be a lot clearer to visualize the intrathoracic structures with the chest windowing in place. So if I scroll through, you can see just how much better it is at looking at the chest. Within here, as an incidental finding, you can see these round lesions, which are centrilobar emphysema. There's a few down here. Good. And you can see some pleural effusion on the right side. And we come down, and at this point you then start developing that lesion there. This here is your oblique fissure, and this side of the lung, aside from the emphysematous changes, seems otherwise clear. These are your ribs here, and those I can't see any fractures, no suspicious lesions in there. And if we follow these vessels for identifying a PE, there was no PE on this image. This is the liver with contrast within it. That's normal looking. And then we're going back, and you can see the heart, so all the contrast within the heart is shown here, and the pulmonary trunk, etc. Good. Excellent. So in conclusion, this appearance is consistent with locally advanced lung malignancy, and you'd normally get histological verification for the diagnosis. So that would be tissue sampling with bronchoscopy ideally. And there's one other thing that we can see on here, which I'll try and get it a bit clearer. So like I said, this is looking from the top down. You've got in here your trachea and esophagus, and if you keep a close eye on the esophagus itself, you'll see as we go down and the lesion begins, you see how narrow this esophagus becomes, and so there's mid-esophageal narrowing because of this, and that can cause a whole host of symptoms and problems for the patient, to the point where they may get NG tube or peg fed if it becomes severe enough. Good. And so this is case number 2 that I have, the last one of our CT section, and this actually is a 17-year-old gentleman with infective symptoms as his presentation. And this chest x-ray, if you would like to pause, you can have a read, and I'll give you some insight into it shortly. Okay, so this chest x-ray is of the 17-year-old patient. Here on the left side you can see blunting of the costophrenic angle, indicative of an effusion on that side, with a left lower zone circular lesion stroke consolidation, but because of where it is and what it's like, it prompted a cal alert, so again cancer alert, and this was then done and CT'd. So if we have a look at the CT scan, I will just scroll through it in the default windowing, as you would see it, and then I'll show you shortly the chest windowing. So you can see here as we're going through, I don't know if you can appreciate the lesion here on this side. That's the left side. And if I leave it here, is there any other pathology that you can identify in this slice of the CT scan? Please pause. Okay, so this over here is actually a effusion, a very large effusion. I think at its deepest is around 9 centimeters in depth. And then you've got your liver, and we come back up. Good. And so if we now look at the thoracic or chest windowing, you have much improved views. So you'll see here the 9 centimeter deep pleural effusion coming in here and deepening. This right lung field is clear, and there's a normal enhancement pattern of the liver. No bony lesions have been identified. And so overall this image is suspicious of a neoplastic lesion in the left lower zone with associated moderate pleural effusion. Here is an image with outlines of the anatomy just for your reference, and again as a lateral view. Thank you for your attention. Please do scan the QR code or click on the link in the description for feedback. It's invaluable for our tutors and for future sessions. We hope this has been helpful for you, and if you have any further questions, please contact the course administrator on radiologycrashcourse101@gmail.com. Thank you and all the best. We look forward to seeing you in our future sessions, which should be released over the coming weeks.